name is Dr. Sohail Chuktai. I'm an orthopedic surgeon based in London. I'm also Microsoft certified specialist and a telehealth expert. My work for the last 10 years has been spanned across setting up telemedicine solutions, designing telemedicine software, and solving healthcare delivery problems. I personally believe that telemedicine is the game changer. It can bring the patient closer to the doctor in a way which has not been done before. It's a paradigm shifter. So today I am privileged to talk about telemedicine in a bit more length, and I'm very honored to represent Pakistan, my country of origin. Although I practice and live in UK, but Pakistan is my country of origin, and I'm very proud to represent this country's status today in this program. This particular program has a very diverse section of opinions coming in. We've got 4 participants, 4 guests in the program. Let me introduce those guests briefly to you first. As you see on the screen, there is a slide. On the top left, you have got Captain Usman Yunus. I will introduce him during the conversation in more detail. On the top right, you will see Dr. Zakiuddin Ahmed. He's also a person who knows about telemedicine from the very evolution of this in Pakistan. So I will explain him more later on. After Dr. Zakiuddin Ahmed, let me introduce Dr. Soumya Iqtidar on the bottom left of the screen. She is Associate Professor of Medicine in the King Edward Medical University in Pakistan. On the bottom right, we've got Dr. Sara Khurram. She's a philanthropist, a telemedicine philanthropist, and has set up a very important project of Pakistan where telemedicine provides doctors a means to earn and also a service structure to Pakistan. So thank you very much for listening on introduction. We will go through details, flashcards as you speak to the speakers. It's Dr. Sohail Chuktai. I'm thankful to Svetlana Efimova for setting up the conference and including Pakistan Telehealth Space Session. It's an important development in the space of telehealth within Pakistan, and I would be glad to host the session that is to follow. Clinical telemedicine is bringing a true healthcare revolution in Pakistan. Allow me to share some of the thoughts on that particular one, and whatever I'm going to share today will be representing the direct work I have been involved in Pakistan by designing telemedicine software and by implementing the solutions in the real scenario. So telemedicine, the clinical telemedicine means that doctor and patient are meeting over telecommunication assisted by a clinical decision support system. It's not just audio-visual communication. The clinical decision support system is part of the clinical telemedicine setup. So in that scenario, we have direct telemedicine when doctor and patient meet on a website or through an app without assistance of any mediator or clinical assistant. An example for that we implemented in Pakistan is this particular project, which was the telemedicine 24/7 helpline, which has seen a large number of patients, around 1 million patients put through, who were given a chance to see a doctor directly without the help of any assistant on the telemedicine software. And I designed this with a view to minimize the learning curve both at the doctor and the patient side, as this was put up in a fairly short space of time to assist reduce the load of patients going to hospitals and clinics in Pakistan. And that project is still running. Then there is assisted telemedicine, or a hub and spoke type, where there is a fixed spoke That's the point where the patient would come in and be assisted by a clinical telemedicine assistant or a coordinator who will connect the patient to a doctor through a laptop or a tablet available at that particular spoke. Now, this spoke can be fixed like a basic health unit in Pakistan, like in villages where there are um, junior doctors, primary care physicians, or at times a nurse or a dispenser only. And then the mobile spokes where a motorbike rider can reach the patient at home who cannot see or cannot visit the basic health unit. Now, this particular project was implemented by, again, at a large scale in Pakistan. And I designed this project. In Urdu, we call it Sehat Ghar, or the House of Health. The idea was to connect the basic health unit with a specialist in a teaching hospital or a district hospital, so the patient does not have to travel. Now, these Urdu names, they are translations of clinical psychologist. Like here, we got speech therapist, we got cardiologist. So these were the specialists who were logged in at district hospital, and they were taking appointments from patients on telemedicine who visited basic health unit where there was no specialist. And this was by appointment, whereas the project you've seen previously, the doctor was available online 24/7. So the difference between the two is that here you got an appointment to make, whereas in the project before, the doctor was available online 24/7. So then we have hybrid model where you have both online appointments, instantly available physician, or by appointment, and that's hybrid model. In that case, this was a project we implemented in the private sector, and this project enabled physicians to offload the rush of patients to clinics, to private hospitals, so that doctors are safe, the patients are safe, and there is less traffic and transmission of the disease in the COVID, first phase of COVID in Pakistan. So now, as you see here, this is a demo of software where a doctor is in the corner. There's a doctor screen, so the patient screen is bigger, the patient image is bigger, and doctor has certain tools on the left-hand side and some tools on the right-hand side to interact with the patient. That's a clinical telemedicine software system, which we designed for Pakistan, different telemedicine requirement systems. Now, in this case, you see that here we got a form coming up, which is a Corona's evaluation score form. That is what we use in Pakistan to segregate the disease burden into different categories. Then patient was able to upload the reports, and the doctor and patient can comment and see together. Same way, patient could take a picture through mobile phone of the X-ray and upload through the same system, and record certain visual findings which doctor can compare later. And doctor can also record the vital parameters and then examine on a video-to-video consultation within that software, and then make brief notes, write initial diagnosis, request further tests, which can be directly sent to the path lab, and also make a prescription, which can again go to pharmacy directly from the doctor's portal. The patient education system was a very important part of this particular drive, especially in phase one. We had to train patients on hand washing and avoiding touching surfaces and following the protocols. So here is a doctor explaining on a YouTube video during a consultation. A doctor can show a clip of anybody on YouTube to demonstrate a technique, or can show pictures and then can send these pictures to the patient if the patient requests so. And this story was taken up by Pakistan has been taken as one of those 7 countries which fought COVID very well. And one of the reasons why we did so, apart from other policies of the government, was a timely deployment of telemedicine. So we were encouraged to write a book by a British publisher, and I involved my senior colleague, Professor Angus Wallace, to join me in this venture. And we did the book together, which was forwarded by Professor J. Saunders, who is the founder of American Telemedicine Association. He's my mentor, and I've taken his advice at time to time in different sectors. So he wrote a forward of the book, and this story is actually the narrative of Pakistan's telemedicine success. Like, it started on 12th of March when I was invited to a press conference in a medical conference. That was the day when the lockdown was announced, and I suggested telemedicine to be used as a tool to fight the COVID onslaught, like limiting patient movement to the hospital. This was taken up by the governor, who met the vice chancellor, and they decided to implement that idea. And then everything was hurried up. Telemedicine centers were set up, starting from the University of Health Sciences initially, and then it spread to many other universities. It was inaugurated by the governor of Punjab, and that is where all the major departments and the political will of the government got involved, along with academic drive from the vice chancellor, Professor Dr. Javed Akram, and the governor got involved directly with all the modalities, all the higher level officials from different departments joining in the program. And then this went on, and then eventually it moved further. It was advertised on the national scale. Doctors were trained. I got involved in training from UK, and I was giving online training using local coordinators. Governor Punjab, Chaudhry Mohammad Sarwar, traveled with my team in different places to have it implemented in different universities. And then the training went on in different universities. And this was a national phenomenon. It was taken up very successfully by 5 medical universities and 17 medical institutions altogether, where we created telemedicine hubs. And we had an opportunity to examine more than 1 million patients. And I'll show you the data in a moment. Even the BBC took a notice, and they published a report on the success of telemedicine in Pakistan. The whole project was judged by international educators. Here's Professor Angus Wallace taking a look at the program, and then the different experts involved. They looked at the evaluation of the value of the project. Then we gave a briefing to the President of Pakistan, who came to University of Health Sciences a month after the telemedicine helpline was installed. He was very happy with the results, and this briefing eventually encouraged us further to develop telemedicine beyond the confines of one province and go into other provinces as well of Pakistan. So this is a story of success where a large number of doctors got involved. More than 500 doctors got involved, who were able to review the patients in excess of 1 million. And this telemedicine software was backed up by a telephone helpline. So the patients who could not get on telemedicine website, they could join on a telephone line and be converted again on the telemedicine software. So this is a roster of doctors. This is a cross-section of patients seen in different specialties. You can see COVID took the bulk of the patients. And then at the same time, we started a telemedicine certificate course to encourage doctors to take up this process with more education and more knowledge. And then the success of this particular telemedicine helpline got known to the Health Minister of Pakistan, Punjab, Professor Dr. Yasmin Rashid, and she initiated another project for elective non-emergency services, whereas the basic health unit patients can be seen by the specialist using telemedicine services. And this is where we did the field tests in small villages, and we were able to scale down the telemedicine software to 356 kilobyte upload speed, which is the speed of a 3G connection, where that means the internet may not be required. It could be just a network connection enough to do the telemedicine. So this is where we started training you can see the masks coming up now. We started training the vaccinators, the dispensers, the technicians who were at the basic health units to be able to connect the patient to the doctor. And then the doctors were sitting in the district headquarter hospitals, and they were able to see those patients through the software and give advice. So patients did not have to travel. And that was not just convenience, it was safety for the doctors and patients both. We lost about more than 100 health professionals in a short space of time. So the doctors were scared to meet the patients in this time as well. And then this is a story of success. And as you can see, that Sehat Ghar alone has so many specialties involved. Then this project went into ICU. We started doing tele ward round of the ICUs. The consultants based in UK, Pakistani consultants, they started doing telemedicine rounds on the specialized software. And BBC again published a report on that particular software that doctors living abroad can help patients in other countries through specialized telemedicine software. So I'm glad to report today to the audience that Pakistan has more or less led in one form or another telemedicine services in the region, not just doing video audio calls, but actually doing clinical telemedicine, which is what I support. And I support a culture of telemedicine rather than the product. We have taken a start from the product. We went through a service, and now in Pakistan, we are touching the culture of telemedicine, which is where the success will really emerge from. So as you've now seen my presentation, which gave you a snapshot of telemedicine's technology structure, but I think it's time to talk to people. So I'm going to address one of my very worthy participants and ask him some questions relevant to his field. Before I go to Captain Usman Yunus, take a look at the flashcard. So, as you've seen on the flashcard, the gentleman has a huge credential list. And I think it was good that I had an opportunity to show the flashcard rather than talk about him. It's going to be taking huge minutes to talk about his career. He's enthusiast in telemedicine. Captain Usman Yunus, I welcome you to the program.
Thank you.
I think you have been the champion of remote healthcare, the virtualization of healthcare in Punjab. And Punjab is 110 million people population. It's bigger than many countries in the world. So I'm going to ask you some very pertinent questions, and I think you can speak from heart. And let me talk about the basic health unit structure in Pakistan. I remember when I was working in Pakistan, people used to go to basic health units, which is a primary structure where people go with pain, with swelling, and etc. Now, at that point, there is no specialist available. How can you connect a specialist on the basic health unit? Because the district headquarters hospital may be miles apart. So have you done anything regarding that?
It's a very interesting question, Dr. Suhail. I'd like to address this question in the context of COVID. You see, telemedicine is now talked about for long. People have been talking about the utility of telemedicine, but because of certain reasons, telemedicine has not been able to kind of kick the initiative that it was. Somehow or the other, we should take it to our advantage that COVID gave us this opportunity whereby we could kickstart telemedicine as a project that has paid us a lot of dividends, and it has been fruitful. It has proved very beneficial for the general public because of the peculiar scare that the COVID created in the beginning. People were reluctant to go to the healthcare facilities. The doctors and professionals at the healthcare facilities were kind of reluctant to physically examine the patient. So this environment, gave us an opportunity, and we were lucky enough to have this political leadership in Punjab in the shape of Professor Yasmin Rashid, who was very kind and very forthcoming in kind of giving us this leverage to pilot this project. Through this pilot, we made sure that the basic health units were connected to the tehsil level hospitals and district headquarter hospitals remotely, and we made sure that the patients were examined at a particular BHU through this telemedicine project by specialists. We not only achieved in bridging the gap of that particular environment which was created through COVID, but we also made sure that a lot of patients benefited. Yes, we have up until yesterday, we have examined about 2,700 patients through this project, and we have their feedback also. And we've also been able to take it to 37 tehsils in Punjab. At the moment, we are in this pilot, and we're trying to make sure that this pilot is eventually graduated. When we graduate it to the rest of the Punjab, we have different other models also in mind, and we want to include the pharmacies as well as the blood banks, right, the testing regime, and the pathology labs that we have. We want to connect those to this system, and we want to make sure that we have a one umbrella solution for everyone. through this project. So,
and how did you manage the software technology learning curve in this? Did you have a special software?
yes, we joined hands with the company which provided us this software free of cost, and the only liability of the company was to provide that software and expertise to us. But at the same time, we were the ones who provided human resource. We were responsible for arranging doctors, their training, the specialists, and we were also responsible for making sure that the right amount of hardware was there, fiber optic solutions were there, the high speed cameras and better internet connections was also there. So it was a very useful pilot that we can actually pitch for the larger upscaling program that we have in our mind. At the same time, I'd also like to tell you that this project will be a game changer. This experience that we've had through this pilot will be a game changer in establishing telehealth medicine as a robust mechanism to ensure that the public can be benefited. Public in the remote areas can be benefited through interaction with the
and especially when your health minister, Professor Dr. Yasmin Rashid, is herself a very renowned professional, medical professional, it kind of translates the whole benefit very well.
See, having her as the minister is kind of very fruitful for the entire health department in Punjab, because she herself is a very passionate doctor. She looks at every problem very passionately, and that's how she kind of conceived this idea, and she gave us this patronage to pilot this project in Punjab.
That's music to my ears to hear all this. Thank you very much for taking us through this journey. I will get back to you on this particular subject a little later. Let me go to Dr. Somi Iqtidar, and here's the flashcard you see on the screen, which takes us through the relevant credentials of Dr. Somi Iqtidar. So as you've seen the flashcard, she is Associate Professor of Medicine in King Edward Medical College, in fact University, and she has been transforming her work into telemedicine. So I'm going to ask her about her experience of taking up telemedicine in Punjab as a doctor's representative. So welcome Dr. Somi Iqtidar to the program. Now your participation is very relevant because you have been taking up this challenge and using this. So I want you to share the personal experience, the very personal experience. How did you find a doctor like yourself, a busy doctor like yourself, taking up telemedicine to change the mode of practice? Please take us through.
Thank you, Dr. Suhail. I think telemedicine was a game changer, as you told in the beginning, because it gives you the freedom of time. As a doctor, we are always fighting for time to find for our family and also to manage our practice. So it gives us a freedom of time so that you can see your patients at your own convenience. It could be a Sunday afternoon when you can follow up your patients, or even if you are traveling abroad. I think you can, if you find free time over there, you can connect to your patients from there.
Just anytime, doctor,
so
anytime.
Yeah. And also it gives you a freedom of place as well. So it can be your home, or even if you are, as I said, you are visiting abroad, so it can be any country. So that limitation of going to a clinic and to a proper setup and then seeing a patient, that is bridged by teleconsultation.
So geography and time are gone.
I think because you can manage your patients from your home as well, so you can give more time to your family, especially if you have an elderly parent at home or you have little kids, you can attend to them. And many of the doctors, especially female doctors, they give up on their career just because they can't go to the hospital or a clinic because they have smaller kids or they have to look after their household work. So they can easily manage with the help of teleconsultation.
So this can restore the balance of doctor's busy life.
Yes. And also, I think the radius of the practice, that can also be increased by using these services, because your practice is not limited to one city or one country. You can see patients from all over the country or even from abroad, and they can consult you.
So economically quite a good proportion.
Economically quite a good proportion. Another thing which I really find attractive about this is that you don't need a larger clinic or a larger setup with a long waiting line. You know, sometimes there is a long waiting line for patients and you need a waiting area and a staff to handle them. So it also cuts that burden. That patient load can be managed easily by digitalization, and also you can keep the record of the patient safe, because when you are giving teleconsultation services, so you have all the record kept in the software. So when the next time patient comes to you on teleconsultation, you have all the backup in your computer, in your software, and it's easier to connect with the patient. So I think it's very rewarding for the doctors, because they're always struggling with time, and it gives a one-stop solution to many problems.
So personally, you feel that it has changed your way of practice and your lifestyle. It has brought some flavor of comfort, flavor of extra economic input as well?
Obviously, it has brought a flavor of comfort, and sometimes even on weekends or afternoons when I'm relatively free and I want to manage my follow-up patients, I just schedule them and accordingly see them.
And I quite like the point you made, the family time.
Yeah.
So your kids are happy, your families can see you more. And I think this is a dilemma of busy doctors. They are lost in practice, lost in patients. So thank you very much for taking us through this. I appreciate that. So I'm going to take two more guests who are not physically here, but they are very much part of this program. Let me go to Dr. Zakiuddin Ahmed, and before I go to him, let's take a look at this flashcard. It tells you more about him. So, Dr. Zakiuddin Ahmed, we have worked together for 20 years almost, and you've seen the telemedicine being evolved in the country. And I remember the countless discussions we had. Tell us about the evolution of telemedicine or telehealth in Pakistan. I'm going to ask you about the technology development and the mindset development both.
Sure. Thank you very much. First of all, allow me to thank the organizers of Atlanta, a dear friend, everyone who has made this conference possible. There are a lot of people who contributed in making this happen. Thank you very much, Dr. Sohail, for organizing this session. I'm grateful to each one of you and all who have contributed. It's always a pleasure and a privilege to be part of a telemedicine conversation. And someone like me who has been at this, journey from the get-go, which is around now it's around 23 years, entering the 24th year running. When I kind of started talking about telemedicine in Pakistan as early as 1997. And then we were lucky that we were able to organize Pakistan's first national telemedicine conference in 2000, way back in 2000 in Karachi, which was a national conference. And then in a couple of years, we organized an international conference. And that's after which Dr. Sohail, when we met, and then it was, we connected immediately, and then after that, it's a great journey together with you also. So, the work in Pakistan started formally in 2000 when we developed the National Telemedicine Forum. It was initiated by Professor Ataur Rahman, who was in the government and who kind of agreed and appreciated the role of telemedicine. And we created a forum together, and then we organized this conference in Pakistan, which was the first time when stakeholders got together. But unfortunately, as it happens, and especially in our part of the world, people drive things. And when he left, the National Telemedicine Forum ceased to exist, and then we again struggled. So I have to be fair in saying that we have been actually struggling. So then we established the eHealth Association of Pakistan. I have been the founding trustee and the president of the eHealth Association of Pakistan as well. But again, I have to admit that we were not successful in creating that momentum in Pakistan. Although we did organize a huge conference, but then the momentum slowed down and kind of fizzled. It was the time when Dr. Sohail, you and I started working on various different projects, and then we, worked on a software which actually became the first of its kind, where we developed a platform and created the virtual hospital, etc., etc. And in addition to obviously, our contribution, there have been many others, but not enough, I would say, that we could take telemedicine, or we could take off with this the concept of telemedicine in Pakistan, up until when we all faced COVID-19, when actually, like the whole world, Pakistan also, people in Pakistan started using telemedicine a little more than they used to. The other part of your question was that, other than the technology, I believe that, we are still struggling when it comes to the patronage and visionary leadership and guidance from the government regarding telemedicine or digital health. It is still not there, unfortunately, which is there in most of the countries in the region as well. Saudi Arabia, India, all of these countries, UAE, they have their governmental forums. But in Pakistan, I'm afraid that we're still struggling, and all of us are trying to work on that level. Physicians, I would say that again, are not really truly on board, and they are still grappling with the fact that they have to see patients remotely. Although COVID helped in that respect, but I would say that in Pakistan we have still a very long way to go, and it means that Sohail, you, I, the other speakers, Sarah and others, and so many others, mashallah, we all need to work together, and we need to synergize so that Pakistan comes on the map of telemedicine as soon as possible.
Thank you, Dr. Zaki. It was very good to hear what you just said. But let me ask Dr. Sarah Khurram. Before I speak to her, here is a flashcard which shows some detail about her. So, Dr. Sarah, you have done philanthropy in telemedicine in Pakistan. Your name is linked to philanthropic projects of healthcare. Can I ask you something about the telemedicine as a tool to solve healthcare problems? Tell us what you have done and how you solved a healthcare problem.
So thank you, Dr. Suhail. It's a pleasure to be on the panel today. My journey relates to my being a female doctor in Pakistan. Majority of our medical workforce in the country is made up of females, but unfortunately, only 1 out of 4 of these female doctors get into formal practice, and rest become doctor brides, doctors who get educated but don't work. And I was in a similar place where I couldn't work after a baby in a new city. And the only thing that saved me at that time was to provide consultations in another city on call to a patient. And that's when we realized that if 50% of population of Pakistan does not get access to a doctor in their lifetime, how can we use this pool of female doctors sitting at home, not being able to serve their communities, to patients who need healthcare using a telemedicine based solution? And with that, we started the organization. We started creating chains of clinics in low income communities where we partnered up with traditional clinics and nurses running those clinics and upgraded those clinics into telemedicine centers by training the nurses on telemedicine software, by them connecting the patient to an online doctor. And later on, we also provided a mobile application to smartphone users to be able to talk to a doctor independently as well.
Thank you, Dr. Sarah, for taking us through this. Let me take the next question to Captain Usman Yunus. And I think this question is about your previous answer. So, Captain Usman, the quality control of telemedicine-based healthcare, what challenges have you felt and how did you manage oversee them?
I'd like to answer this question in 3 parts. You see, when we talk about quality of telemedicine that we piloted in Punjab, we will tend to compare our telemedicine quality with the otherwise quality that we have. So when we do that, we must take into account that telemedicine does not have the level playing field the other consultants have otherwise.
Right.
When a person physically approaches a particular consultant, he or she has a kind of comfort that a doctor has physically seen me, he has touched me, he or she has kind of patted on the shoulder and said, "Gentlemen, don't worry, you'll be all right in 10 days or 5 days." This kind of interaction is not available remotely on a telemedicine platform. So these are not two level playing fields. So when you talk about quality assurance, I mean, You have to be damn good on the telemedicine platform to be labeled as a good consultant. And you just have to pat on somebody's shoulder in a physical examination and you'll be labeled a good consultant.
That's interesting.
In our society, so you see, when you talk about quality assurance of these two platforms, they don't enjoy a level playing field. So when I say that they don't enjoy a level playing field, it is a very big challenge for us at the public sector level, we who are the policy makers, to ensure that this telemedicine gets the amount of patronage it deserves, so that people are, kind of susceptible to this project, and they see it as a game changer. So that's one aspect of quality assurance. The other aspect is when we piloted this project, we had a ready-made solution to our hand, available with us in the shape of a software. That's a perfect software. I mean, in any environment, it's a very good software. It's an excellent software. It has all the features available to it. I, for once, actually, experimented it as a patient, and I found out that it was very convenient to use, not only as a patient, but also from the other side of the platform. When you're sitting there as a consultant, you don't need to be very tech savvy to use that platform. It's a very, very convenient to use, simple interface. Anybody who uses a computer can very easily use this particular software.
That's a very strong endorsement.
Yes. So, but at the same time, through this pilot in our environment, we've also kind of suggested some improvements. We feel that this software should also be connected to our laboratory services. It should be converted through our pharmacies. I mean, somebody who has taken a consultation from a telemedicine platform shouldn't be roaming about different places to take that medicine that has been prescribed to him or her.
Yeah.
So it's very important that these interfaces are interlinked. Our pharmacies are also in that particular platform, incorporated into that platform. Our blood banks, our blood services, our pathology services, everything has to be kind of connected in a particular healthcare facility with this platform, so that you get a one umbrella solution. When we incorporate all these into the system, then the quality assurance will be entirely different from what we have today. So today you have a pilot where somebody has particularly gone to a healthcare facility, which is a BHU, and then he or she has been made to consult a consultant. That's about it. That's the only interface we have experimented at the moment. But when in future, through the same interface, he or she will get a particular medication from that BHU without going through any hassle, the quality assurance of that particular project will be entirely different. The third part is the actual training part, through which we kind of initiated this project. I personally feel that it was hassle-free. There wasn't much of problems that we encountered. It was only setting up of a platform whereby we created an environment where those consultants would gather at a particular time frame in a day, and then they would be connected with all the VHUs around them. There was a hub and spoke model, and the only thing we did was a couple of hours training all of them together. So that was enough. So I think as we go along, as more people are involved into it, we will only have to undergo trainings and maybe some refresher trainings while we kind of make incorporations into the software. So it went hassle-free. But at the same time, our level of comfort will only come when a particular patient has certified the quality of healthcare service given to him or her. So that will come through a rating system which is incorporated into the system, into the software, whereby a patient at the end of a particular consultation will have to kind of rate how the consultation went about. So I mean, these three aspects, one is the social aspect through which you have to make sure that quality is seen as a quality healthcare service with the public, and then the other part is the improvements that we envisage, and the last part is about how we make sure that our healthcare professionals and our staff that is involved in the entire framework is kind of trained to do this.
From this question, this answer you've given, I have a different scenario emerging, and I'm going to talk to Dr. Somi Iqtidar about it. You mentioned about the visual examination of patient's mindset. Unless the doctor touches me, it's not consultation. As a doctor, where do you see patients causing interruption or interference with the adaptation of telemedicine? Or what is the patient's perspective? How do you manage that?
I think it's a new thing for it's new for the doctors as well as for the patients, and it will take some time to get customized to this new modality of treatment. But we need to build confidence of the patients.
Absolutely.
And physicians who are practicing telemedicine, physicians and surgeons both, since you're a surgeon, I know you're touchy about it. So doctors, both physicians and surgeons who are practicing telemedicine, they should enhance their clinical skills that and it will with the passage of time, so that they have improved clinical skills with the passage of time to have a detailed visual survey of the patient to come to a diagnosis. And if there's any gap that can be bridged by technologies in the software, by adding gadgets to it, like an ultrasound probe can be added to it, a dermoscope can be added to it, and
like an
also
camera, dental camera.
Yeah, dental camera. And also investigations help quite a lot. So I think this gap can be bridged by these small changes, and with the passage of time, once they start practicing this telemedicine, this will actually enhance their clinical skills, and they will be in a better position to look at the patients through a software.
And also, I just want to add to this, a good history taking is of course available through video.
Yeah.
And by experience, 70 to 80% diagnosis is done on history.
Yeah, but Dr. Suhail, I think it requires a lot of good communication skills as well, because when you are talking to a person with an eye contact, that's a different story, but when you are talking through a camera, you have to be very good at communication skill. And I think telemedicine is an opportunity, because people will develop good communication skills, especially doctors, because that the level of the camera in a laptop or in a tablet is different from direct eye to eye contact. So they have to customize themselves according to that they have to see on the camera, make an eye contact, explain everything in detail, give more time to the patient, elaborate everything. So it requires some effort, which is good. I think we should take it in a positive way, because it is going to enhance their clinical
I
skills
strongly
and
believe that,
communication.
because a good history and whatever is left in the history, that's visual examination can cover it. Whatever is left in visual examination, investigations can come and play and plug in that part. Personally speaking, I do not operate on knee unless I have an MRI scan. Even my clinical examinations in click show a rupture of anterior cruciate ligament. My patients won't let me, because they say, well, why don't you get my MRI scan done? So in the current scenario, we do not have the opportunity medico-legally to operate even if you physically examine and you're sure. The scenario has changed, and I totally agree what you just said. Thank you for taking me through this. I'm going to connect this question to my next question with Dr. Zakiuddin Ahmed, who's far away from here, but not very far. Dr. Zaki, take us through the commercial journey of telemedicine in Pakistan. All this is great, the academic discussion is very good, but how can people take to telemedicine in commercial market? You've seen this all, and take us through this journey.
I think it's very discouraging as far as the commercialization of telemedicine is in Pakistan. I'm afraid that most, if not all, of the telemedicine initiatives and projects are either still in the pilot or proof of concept phase, or they are supported by funding from different organizations. We are yet to see a truly business case or a business model of a successful commercial telemedicine venture in Pakistan. And that's because of various different reasons. And I don't think we have time enough to discuss those reasons. But the answer to your question is that Pakistan, in its journey or in our learning curve of telemedicine, is still in a phase where there are a lot of pilots, and as we say, the pilotitis of telemedicine is still there in Pakistan, I'm afraid. So, and then the proof of concepts which go up after a year or so, because they don't have a sustainable commercial model, they just go down. Most of the projects and initiatives that are still running are essentially running on funds and grants. So I think that after COVID, where we see that the Western countries, especially the US, have actually created a very clear business model, and the rules and regulations have also eased. So you can start doing telemedicine on even a telephone call which is now taking place in the US and which is reimbursed. So I would, and I think it's a brilliant question which you have asked, because until we have a good reimbursement model for the healthcare providers, physicians who are going to use telemedicine, until we have a good reimbursement model, until we have a good business case for telemedicine, I think with an experience of now 23, 24 years of struggling for promoting telemedicine, that we will continue to struggle. So I think that all of us need to work on developing these commercial, viable, sustainable models for telemedicine. In addition to the value added, value addition, with the extraordinary value addition which telemedicine brings for the patient. So that is still there. But a few of the companies have started to realize that, and now they are starting to interact with investors and financial partners, and partners who are working in the other spaces. So chain of pharmacies are a good example. So they are now coming into this space because they see that there is a commercial and a business case there. So maybe in the next year's conference, we will be able to come up with a few good commercially viable and sustainable models from Pakistan.
Thank you, Dr. Zaki. This is wonderful to hear from you. Let me talk to Dr. Sarah Khurram. She has done the philanthropy in telemedicine, and I want to ask her, Dr. Sarah, what difficulties you felt in getting female doctors on board in telemedicine? You've done this project in Pakistan, and take us through the journey of difficulties you faced and how did you manage to solve them?
So I think the whole idea of getting a female doctor sitting at home, providing healthcare in low-income communities is a very new idea that was difficult to convince people about. But I think especially in the low-income communities, setting the infrastructure, so making sure internet is available, electricity is available, the nurse is trained, we have resources who understand the work, was very difficult. But I think the greatest challenge was making the patient understand that this doctor that they're seeing online is as good as a physical doctor, and certainly much better than the quack that they would have to go to if this doctor was not available. So I think getting people into the clinic to experience that setup was the biggest challenge. But once they came in, once we found nurses who became our champions, we found female mobilizers who did the education in the clinic. And once the patients started coming in and started seeing the online doctors, and when they got well, I think the word of mouth spread, and that really helped in us getting traction in the clinics. With time, we also improved our needs assessment. So we found clinics which were much better suited to telemedicine, communities that were more receptive. So with time, our own operational capacity increased, and we found more and more areas where this could be more successful, and we can have longer term impact in those communities.
Dr. Sarah has just given us a very good overview of this, but I want to get back to Captain Usman Yunus. He's very much relevant into regulations and certifications, and I think Pakistan has to have a system in place where the quality control of the telemedicine practice has to be regulated. Let's ask Captain Usman, where do we stand in Pakistan?
I think it's a very, very relevant question under the circumstances. You see, in Pakistan, we've had bad examples to quote, in where there were private organizations, NGOs, working on the model of telemedicine. They set up satellite clinics, and those satellite clinics were kind of backed up through consultants in the end. That was the idea, that you will come to a particular satellite clinic, you will be made to connect to a specialist through this entire apparatus. But our experience was that in the end, those consultants on the remote places vanished, and those satellite clinics became places for quacks to operate. So Punjab Healthcare Commission at the moment does not recognize telemedicine in the private sector as such. The agenda is on their agenda, and they are kind of thinking on how to regulate this for future. But at the moment, for the reason that I've kind of told you, I don't see this as a very, very welcoming gesture at the moment, because of the particular reason that I've told you about, because these satellite clinics will eventually become sources for quacks to operate,
right,
unless we have a very, very clear foolproof mechanism to check each and every satellite clinic for such incidences, I don't think private sector will be into this telemedicine business in the near future. At the same time, when you talk about public sector, at least public sector will make sure that the services being provided are through recognized consultants and MOs, because every procedure in the public sector will eventually be documented, and there is no possibility that a quack will eventually kind of get into the system.
Because the doctors as well.
Obviously, our doctors are on a particular duty role, and they are otherwise sitting at a particular healthcare facility. They will be the ones who will be connected. We will be monitoring through the entire software which particular doctor has examined a particular patient. So in a public sector environment, this is very much possible as long as certification is concerned. At the moment when we piloted this project, we made sure that the facilities that were operating in this project were duly advertised and publicized. As we go along, we can kind of think about initiating a particular model where we certify certain people to be qualified for handling telemedicine projects in our hospitals, and not only doctors but also the support staff that is needed to operate. And I don't think that much is required to be done. It's just a simple training that will happen, and may include some handling of the interfaces of the software, and handling of the interfaces of how to get into the patient history, and how to communicate to those patients. I mean, communication skills will eventually play a major role into this entire telemedicine system. Unless you are familiar with how to communicate with a particular patient, a particular doctor or a consultant will not be able to achieve the success that we want this system to deliver.
And I absolutely agree with you, because the telemedicine failure in certain sectors is not because of patients. It is because the doctors could not get used to it.
That's right.
So I agree with you, and I want to shift the question balance to Dr. Somi Iqtidar. Patients. Patients, can they be the defeaters of telemedicine, or can their life be changed? There are two parts of the question. Let's focus on one part at a time. How will patients' life change because of telemedicine? How will the patient buy this service?
I think patient's life becomes very convenient with the proper use of telemedicine, because telemedicine cuts down on the economic burden of travel, then logistic support of the travel, and also the social burden, because sometimes people have they need somebody to accompany them to a clinic or a hospital, and through telemedicine services this can be avoided. They can simply book an appointment and consult the doctor from the comfort of their home. And if you are a good teleconsultation provider, I think it's just like patient feels that if doctor is visiting their home. Some of my patients, if I share from my practice, there are some patients who are very old, or who are bed bound, or who are very terminally ill patients, and they find it very difficult, the family finds it very difficult to bring them to a clinic for checkup. So it's very easy for them. Previously they had been telling me that it was very difficult for them to take them to the clinic, so they were not seeking healthcare at all. Because if they go with only the lab reports to a doctor, the doctors they sometimes refuse to see, because they say that this is not the proper thing,
so it makes
because
a big
patient
difference.
is not here. So now through teleconsultation they can promptly take healthcare advice from the doctor by booking an appointment. And also sometimes patients they are in a situation of panic where they want to get to a doctor very immediately and promptly, and they cannot get an appointment for weeks with the busy doctors. So this teleconsultation services also bridges that long waiting list.
Right.
And another important thing which came during the pandemic of COVID was that the COVID patients, they need isolation, and proper infection and prevention and control should be maintained. And you cannot ask every patient to go about in hospitals or clinics, because they have to be isolated from the rest of the community. So this provided an excellent service in those times, and the times are going on. And also patients of other ailments, like who needed regular follow-up, like diabetes or hypertension, or patients of chronic liver disease or chronic kidney disease who need a regular follow-up. They were scared, and they feared going to hospitals and clinics because they thought that they would catch infection. And these patients are immunocompromised, and so they are more vulnerable. So the continuity of the care was maintained because of the teleconsultation services. We had a huge burden of COVID-19 in Pakistan, and in the hospital in which I work was a designated corona hospital, and we had to close the OPDs for some time because there was so much patient burden, and we could not allow crowding of the patients in the outpatient departments.
So you're referring to doctors' 24/7 telemedicine helpline.
Yeah, that also helped, because patients could continue with their follow-up visits through teleconsultation. And in COVID-19, you also know that patients not only need isolation, but they also need careful and regular monitoring, so that if they are going into a higher grade of the disease or more severe disease, they could promptly be diagnosed and referred to a hospital. So if you are in regular touch with your clinician and you monitor your oxygen saturation and your labs, and you get in consultation with the telephysician, he can guide you that what stage are you in, when can you break your isolation, what is the time to go to a hospital, all this stuff. So I think this helped a lot in providing the continuity of care in the pandemic situation.
So not every consultation requires a physical visit. Like infertility clinics, they don't require physical visits. Managing diabetes, they don't require physical visits all the time.
Yeah.
Managing chronic cardiac failure sometimes does require only beta blocker change. So what challenges, Dr. Soumya, a doctor would face in setting up a telemedicine clinic from your personal experience? Take us through.
I think the biggest challenge in our country would be finding the right equipment and the right software and an internet facility which has a good speed, so that you are connected all the time with your patients and you have no hookups. So apart from that, you also need a setup with the privacy, because you are dealing with patients, and the confidentiality of the patients is also very important when you are giving teleconsultation services. So maybe these are the two main challenges. And third, as previously pointed out by different participants, that we need to build confidence of the patient on this new modality of treatment. And the confidence will be built only if you are yourself convinced and you are yourself an expert in using this software. The more you are aware and you are easy with that software handling, the more confidence you can instill in your patients. And if you are confident enough to convince them that you are providing state-of-the-art facilities to them, only then they will be adopting to this new modality.
So they have to know
treatment.
software well.
So they have to know software well, and I think doctors have sometimes they have to be an engineer, or I should say a software IT person, because they have to make troubleshootings. People have sometimes connectivity issues, sometimes camera setting issues. So
But won't they learn on the way? They don't have to develop special learning. They will learn on the way.
Yeah, doctors will learn on the way, but sometimes you have to help the patient as well. And the literacy rate of Pakistan is not that high. Not everybody is literate or computer literate. Yeah. So this is one big challenge. Another challenge may be that it is difficult for patients to seek if the doctor is not actually visiting them and physically examining them. But I think this can be overcome by having an excellent visual survey and building up your clinical skills, that you can diagnose a patient by taking a detailed history and a visual survey of the patient.
And good communication skills.
Yeah, and good communication skills. I think that's the cornerstone of any patient-doctor relationship. If you can communicate well with your patients, you can make an eye contact through a camera of a laptop or a screen, I think that helps a lot. Also, the gap that is there, that can be bridged by adding on services, like you can have, if you are examining a dermatological manifestation of anything, you can have a dermoscope attached to your software. Or if you need an ultrasound or an echo, then you can have, if it is hub and spoke model, you can have an ultrasound probe at the center or an echo probe at the center, or even a stethoscope. Electronic stethoscope
so
can be attached to the software.
Examine a patient as well.
And another thing, which is I think we should never forget, is that patients should feel empowered. So patients should think that they are visiting their doctor. Absolutely. I think the confidence that we need to build in the patient, that is very, very important.
And that mindset can be only converted if doctor is confident in using software. Imagine a doctor is distracted by software. Patient is already lost. A doctor has to make the software invisible to win the confidence of the patient. And that is what the responsibility of a software developer is. And ideally speaking, a doctor should make a telemedicine software. That is what I believe in. Thank you very much, Dr. Soumya. I want to go to Dr. Zakiuddin Ahmed at this point and ask him a question that regarding the making telemedicine taken up by institutions. How do you institutionalize telemedicine in Pakistan? Let me ask him this question, and he's got a lot of experience behind to answer this one.
So I agree with what you have mentioned, because and that has only happened essentially after COVID struck the whole world. Essentially, although the efforts by you and other people also, all of us from like 2019, the momentum had started, but it really took off when the universities and the government officials, people at the helm of affairs, they realized, or they just saw that the whole world is using telemedicine. So yes, I think you have done a great job in bringing the government together for telemedicine. We all are working with the government in different respects. So it has started, but again, the first is it's too late. I think we are already late. Second, it's too slow, and the third is that, like any other country in the world, as soon as COVID goes down, and as soon as the hospitals and OPDs open up, immediately there's a downward trend in telemedicine. So physicians are still not really comfortable. Organizations and the government are still, they're not really behind using technology for remote consultations or providing healthcare services to patients using digital health tools. So I think a lot of work still needs to be done. One of the things which I would like to say here is that after going through the whole curve of the National Telemedicine Forum, which I believe that started the momentum, but then it died. Then the E-Health Association of Pakistan. I believe, and I've always believed, and I've seen this in the world, that we need to work together. And even in Pakistan, I think that's lacking. So what we have done, and Sohail, you're part of that. So we have created this Digital Health Pakistan initiative, where we are now bringing together all the stakeholders, not only telemedicine experts or people doing telemedicine or the technology people. We are bringing together experts from the health informatics space, professionals who are taking care of hospital information systems, industry partners who are now working both locally and globally to develop softwares, mobile application developers, physicians, nearly all the stakeholders of this healthcare ecosystem, including the government. So this Digital Health Pakistan initiative, which I am leading, and I have friends like you and so many others who have been pioneers in the last decade and who have led this journey in Pakistan. So all of us together, we are now going to create the momentum of not only telemedicine but digital health and health informatics. I've always believed that organizations like HIMSS and others have been very successful, as opposed to associations like which are just focused on telemedicine. And we have so many examples of telemedicine societies and associations going down, including Canada and others. So I always have realized that we need to bring the industry partners in the equation, because they drive this the momentum. They're force behind the momentum. So Digital Health Pakistan, where we are all together, will be leading this ecosystem, bringing all the stakeholders, and I can assure all our participants that next year the Digital Health Pakistan initiative will present very successful case studies and examples from Pakistan.
Thank you, Dr. Zaki. That was wonderful. It's good to see your view. Let me ask Dr. Sarah Khurram on the next side, that she has faced philanthropy in Pakistan and she's done so much work. Did she actually make an impact? How did Sarah Khurram change the mindset of people through her philanthropy? Let me ask this question to Sarah Khurram.
I think I'll talk about the doctors first. So, a female doctor sitting at home not working, it dents her self esteem. Confidence is lost. They feel lost and not being able to understand why they can't practice anymore. When they come onto our network, they get a community of other doctors. They get a chance to practice flexibly. They get to earn. And they also do what they were always meant to do, serve patients, see patients, and do healthcare. So I think that's the impact we're creating socially and economically on the doctors. Now coming to the patients, I think for a patient who comes into one of our clinics, if that patient had to walk to a tertiary care center or travel to a tertiary care center, it would cost them at least 5 times more. They would lose a day wage. They would have to travel, take food, take a family member. There's so much time and money lost in that equation. But when they come to our clinic, they get all that healthcare within 50 rupees. They get value add services. They get to see a qualified doctor, and most of their issues resolve in the clinic. So they don't have to go anywhere else for a consultation. Economically, they save money, but also from a qualitative perspective. I think when they come to our clinic, they're seen by a qualified resource who spends time with them, takes their history, does their examination, knows their symptoms. They get a prescription based on their symptoms. They don't get overprescribed. There's no antibiotic overdrain in the clinics. So they also get counseled for the disease that they have. And over time, the patient sees that it adds value to their healthcare. We also, as a company, track our patients' journey over time. So we see how many patients came for the first consultation, how many patients came for a follow-up, which diseases are prevalent in which communities. We create our preventive healthcare campaigns based on the data available per community. And we also make sure that we place specialists according to the data that we get. For example, if we see a lot of cardiological cases in one area, we will place a cardiologist there. We started mental health services in our clinics because we found a lot of mental health issues that were unanswered in the communities. So all these interventions make long-term impact and long-term change happen in the community at a quantitative and a qualitative level.
Thank you, Sarah. That was good to know your view on that. I think this has been a program which I have personally loved to do. I have felt very empowered. I've been privileged by having two people right here on my right and left. Captain Usman Yunus, thank you very much for joining this particular program. Dr. Soumya Tadar, you've been very busy like Captain Usman, and you've managed to spare your time. And people sitting far away from us, but nobody's far away nowadays anyway. Dr. Zakiuddin Ahmed, thank you for coming and joining virtually. And Dr. Sarah Khurram, you've been wonderful always. Thank you for sparing time. With this, I wish that we bring a big change. Telemedicine is not a novelty anymore. Telemedicine is there, and it's going to change the paradigm. And Pakistan has already been noted as a success story. Pakistan is one of those 7 countries which has fought COVID well. And one of the reasons why we did that was timely implementation of telemedicine in Pakistan. So that is contributory factor, and that is a telltale of usefulness of telemedicine. Thank you very much, and I hope to see you sometime soon. Thank you.